and ASE is also involved in creating these guidelines. I do come from an MFM lab, and our lab is AIUM accredited, so much of my protocols are based around that, but they mirror each other pretty well, looking at IAC as well as AIUM. And just quickly, I'm not going to go through all these, but I did list what the grayscale requirements are, as well as the color Doppler requirements of all the vessels and the valves. The pulse Doppler should be done on all the valves, as well as the ductus venosus. Of course, if you detect any irregular rhythm or any abnormalities noted with color, should also be documented with Doppler. And your rate and rhythm needs to be done with M mode or Doppler, obviously showing both the atrial and the ventricular rates. And then in terms of the biometry measurements, according to the guidelines, they don't have to be done unless you suspect an anomaly. But I do think it is important to do them routinely so that when you do have an abnormality, you're making sure you're taking accurate measurements. So I'm just going to get right into the protocol because I do have a lot of information to go over. So just like I mentioned, when I start scanning, the first thing that I always do is check for situs. Obviously, if you know that your situs is correct, then you can go ahead and go on from there and start to review the heart in detail. So we do it by taking a sagittal image of the fetus, documenting presentation, and then turning 90 degrees to first demonstrate the stomach, aorta, and IVC, and then sweeping up to the heart to show that it's all correct on the left side. I make sure and get a really good view of the abdominal anatomy to make sure that, again, I'm documenting the aorta and IVC, but I'm also looking for the presence of other vessels so that I may have some subtle clue early on that there could be potentially anomalous pulmonary vein. If you see an extra vein, that could be a vertical vein. Do I note that the IVC looks dilated, meaning that there could be some absence of the ductus venosus with drainage into the IVC? So there are clues to things that you can look at immediately in this abdominal view. So that's first. And then moving from there, you want to be documenting biometry. And I know that the cardiac sonographers aren't as comfortable with the OB component, but you need to make sure that the gestational age is just not taken as it's presented. You need to make sure that the measurements match with what the expected gestational age is. So at minimum, you need to be taking a biparietal diameter or a femur length, but from the MFM side, I think you're obligated to do the full biometry and confirm that the dates are on track. And then umbilical artery and umbilical vein Dopplers listed as optional. In order to be comprehensive, they're quick and easy to do, looking for forward flow in the umbilical artery and no pulsations in the umbilical vein. Your ductus venosus Doppler does take a little bit of extra effort to learn how to do this quickly, particularly for the pediatric sonographers who aren't as familiar with this. But again, just being very familiar with the normal location. You can use the turbulence as a guide as well, but in cases where I've had absence of the ductus venosus that hasn't been draining directly into the IVC, or I don't have right heart enlargement, sometimes it's not there and there's intrahepatic connection, so you might not see clues to that. So feeling very comfortable with the location so that there is absence of the ductus venosus, you can say it with confidence because you know where it should be. So again, follow the umbilical vein back. Right as a junction where it turns towards the right at this level of the portal sinus, that's where your ductus venosus is going to come back straight towards the spine. And again, aliasing isn't always a bad thing. You can turn on your color Doppler and it will help highlight the area of the ductus venosus. So in sagittal, we can do the same thing. We're just following the umbilical vein to its termination point, and you can see this nice aliasing here to highlight where the ductus is. Dopplering, it should all be forward flow. We're looking for, when it's abnormal, reversal of flow in the A wave during the atrial contraction. So moving into our 4-chamber view, a couple different perspectives you can look at in the apical or subcostal view. I do like to look at both, if at all possible, and at some point during my examination I will get to see it in more than one perspective. And starting very simply, we want the apex obviously to be leftward. When you draw a line through the chest, it should traverse the right ventricle and go through the spine, with the majority of the heart being in the left chest. Your axis should be 45 degrees plus or minus 20. And then looking at the cardiac size, when we look at our CT area ratio, it should be about 0.33, and the CT circumference ratio of 0.5, and those values will remain constant throughout gestation, so easy to remember. And again, I know we've talked a lot about what to look for, but I think that the very important points are good to emphasize. So again, moderator band, marker for your right ventricle. Tricuspid valve should be apically offset from the mitral valve, and again, that tricuspid valve defines it as being the right ventricle. Look for the descending aorta. Look for any extra vessel back there. We saw examples of dilated azygos veins. You also want to be looking to make sure that there's no confluence behind the left atrium as a sign for TAPVR. Looking for the foramen ovale flap flapping from right to left. Pulmonary veins should be seen with 2D as well as with color and Doppler. And septum intact. Yes, of course, we're looking in every view, but this apical presentation is not the best view to look at the septum. And then I just watch the 4-chamber moving, and when I'm looking, I'm paying particular attention to the movement of the valves, making sure that they're both valves are moving well and that they're symmetric. Right and left sides, again, should be symmetrical. And sometimes in the 3rd trimester, when you're doing an apical 4-chamber view, it's easy to foreshorten perhaps, or have a technical limitation, and you might think that one chamber is bigger than the other, but I find that this view is more reliable later in gestation to confirm whether or not there is any disproportion or not. So you want to make sure and use different scanning planes to confirm symmetry or asymmetry. And of course, we can make measurements as well, measuring at the level of the valves as well as the level of the ventricles just below the level of the AV valves. Our lab uses this website, parameterz.blogspot.com, in order to check the Z-scores when we make these measurements, but there are calc packages also in most of the machines as well. Things I'm looking at also as I'm coming through, so pulmonary veins, obviously we've discussed TAPVR can be a very difficult diagnosis to make, particularly if it's an isolated anomaly. So I'm looking for the pulmonary veins in 2D first, but this little Coumadin ridge, this ridge of tissue that I mentioned yesterday, is also nice to see when you're looking at the left atrium. What it is it's an infold of tissue in between the left atrial appendage and the left pulmonary vein. So if you don't have a pulmonary vein, such in cases where you have total anomalous pulmonary venous return, you can't have an infold of tissue. So although it shouldn't be something that you rely on solely to make this diagnosis, it is something that is reassuring to see. And once we see them with 2D, so I like to make sure that I have a nice 2D image first, and then I put the color on, and you can actually appreciate the Coumadin ridge with this left-sided pulmonary vein coming in. So again, keep the box small. I try and include the mitral valve as well in my color box to show that the flow is coming into the left atrium and crossing the mitral valve. So scale is going to be low because you're not having high velocity flow through this. So turn your scale down to about 30 centimeters per second. And you want to see at least one vein on each side in order to confirm that there's no significant abnormalities with the pulmonary venous return. And this is to show you the normal Doppler pattern, which we've seen in this conference. So typically it is all forward flow with the systole, early diastole, and then the late atrial kick seen here. So this is a nice normal pulmonary venous Doppler pattern to show that there's no obstruction. So again, next I'm going to look, I've already looked at the mitral and tricuspid valve in 2D. I'm putting the color on to confirm that there's nice laminar forward flow. So ideally the apical 4-chamber view is where you want to do this because you're coming in parallel with the direction of flow. Your velocity scale is going to be somewhere between 50 to 80 centimeters per second. You want to, again, keep your color box small, of course, to maintain the frame rate. And again, nice laminar flow with no regurgitation is what we're looking for. Sample gates, I wasn't able to show this yesterday during the live scanning, so I have it demonstrated here. This is showing where we place the sample gate just past the leaflets of the valve as you're watching it into the ventricle. Your waveform should be biphasic, with the E wave showing your early diastole and the A wave being the taller portion of the waveform showing the late diastole. So in a fetus, the E wave is going to be shorter than the A wave, and then this pattern reverses after birth. Same for the tricuspid valve. As I mentioned yesterday, and again today, very important when looking for VSDs to be using the proper angle. This happens a lot when you're scanning. This perimembranous or the top of the septum will drop out as it gets closer towards the AV valve. So in order to see this, you need to be coming in perpendicular. So do not call VSDs number 1 without using color Doppler, and number 2 without making sure you've confirmed in more than one plane coming in perpendicular to the septum. And of course, color flow needs to be used to look at the septum as well. So again, notice coming in perpendicular. So 4-chamber and short axis views are the typical views that we use. You want to make sure and be sweeping up and down because obviously we know the septum has depth, so you can't confirm it in only one plane. And we want to keep our scale low because in an otherwise structurally normal heart, your pressures on the right and left sides are going to be very close to equal. Also, when you're here in the same view, this is a very nice plane to also confirm the PFO, which we need to see as part of the guidelines in 2D and with color. So this is something that I really try and optimize my image in 2D first, because I find that the color flow can be hard to confirm easily without having a very nice 2D image. So making sure you're seeing the foramen ovale flap well. Again, your scale is going to be lower for this as well, and then put your box just over this area, and then you should start to more easily get this image. So moving into our LVOT view. So a couple different ways. First, coming from the apical perspective and scanning upwards. You want to make sure, obviously, that your aorta is arising from your left ventricle, that there's continuity of the septum as you're looking, and then also that the aortic valve, as you're watching it, is thin and the leaflets are moving freely. Color flow from this perspective is nice also because we have a pretty good angle to look at the flow across the valve. So you should be seeing the flow come all the way across the valve, again, nice and laminar. When you put your Doppler gate on, in this case, you're going to put your gate just past the level of the valve and measure peak systolic velocity. And I like to use just 1 meter per second as my threshold for being normal. So anything under 1 across all the valves. Okay. This is probably my favorite way to look at the left outflow tract, coming from the subcostal view and sweeping up, because again, we're coming in perpendicular to the septum. So this view is essential, I think, to confirm that you have no override. I think sometimes when you come down from the apical perspective, you can falsely create it to look like an override. So if you have any question, it is essential to be coming in perpendicular to the septum. So from this view, I'm looking at the septum, I'm looking at the valve, I'm making sure that there's no override, I'm making sure that the vessel looks nice and contiguous and the caliber looks nice and normal. And if I measure this valve, I'm going to measure it in systole with the valve open at the hinge points. Color flow, again, should be used in this perspective as well. Again, looking at the septum and also looking at the flow across the valve. So moving into our RVOT view, which we can look at in a short axis or a long axis perspective. So in this view, we're looking at symmetry. Pulmonary artery and aorta should be fairly similar in size. The pulmonary artery should never be smaller than the aorta. That's never normal. And again, making sure you're paying attention to the valve while you're looking as well. Those leaflets should be thin and moving freely, and you should be seeing them branching. So as I'm going through in 2D, I'm really making an assessment of what I think is normal or not normal, and then when I put the color on, it's really just confirming what I already figured out in 2D. So then if I see something unusual with the color, I think I must have missed something in 2D, but I don't. I'm very meticulous about looking in 2D first and then using the color as a supplement. This is a perfect angle to put on color. Again, same thing, nice laminar forward flow. When you put your Doppler on, you're going to put it just past the level of the pulmonary valve and peak systolic velocities under 1 meter. And then in the long axis view, this is a really nice view to also confirm that the great vessels are crossing. And I really like this also to look at one more look at the valves if you didn't get a good look at them before. You can see them, they're crossing right at the level of the valves. And then with color, also seeing that the flow direction is different because your aorta is coming up and your pulmonary artery is crossing down. So there's no question with someone looking at this later that these vessels are definitely crossing normally. And pulmonary valve measurements, again, at the level of the annulus with the valve open, taken with your calipers at the hinge points. I take measurements of the main pulmonary artery and branch pulmonary arteries if there's any suspicion of abnormality for the sake of completeness. So your main pulmonary artery is taken right in between the level of the branching and the pulmonary valve as well. We've talked a lot about the 3-vessel view, and I think just given the amount of time that people have spent talking about it really confirms how important how important this view is and how it is really helping us. So it's quite easy to obtain just taking a simple sweep up from the 4-chamber view. Here we can see it coming up here, and then just slightly higher, moving up into the 3-vessel trachea view, confirming that the ductus and the aorta merge at the descending aorta to the left of the trachea. And we've already discussed this. We're looking for the number of vessels, we're looking at the size of the vessels, we're looking at arch-sidedness, and then also normal direction of flow. And then this is also a nice view to look at the thymus gland as well, which sits right in front of these great vessels. If you're just learning this view, this acronym makes it nice and easy to remember with the pulmonary artery, aorta, SVC, and trachea, so past, easy to remember. And again, already merging. This is a good view to look at the aortic isthmus as well as the ductus. You can also Doppler the ductus from this perspective as well as in the long axis view. But I really like this view because it's not subjective. Either the aorta merges towards the left of the trachea with the ductus or it doesn't. There's not a lot of symmetry or asymmetry. It's a very nice and straightforward view for purposes of arch-sightedness. And again, the color flow, you want to make sure that it's all going back towards the descending aorta. Any color flow that's different in one of the vessels is definitely a red flag and tells you need to be investigating those valves and vessels more carefully. This is the view that I use to confirm the branching pattern, so you should be making sure that the left and right pulmonary branches are confluent. And you can see that as they're branching, they're tapering off and going into the lungs. So moving into our short axis view, so just turning 90 degrees on the septum. Again, I'm looking in 2D first. So I'm looking at the size of the ventricles, I'm also looking at the function, and I'm also paying attention to the valves as well. So we can see the mitral valve in cross-section as well as the tricuspid valve. Your right ventricle is your more anterior chamber, left ventricle more posterior, and again, that mitral valve doesn't have any septal attachments, which can be appreciated well in this view. This is also a view that I like to use when we have an AV canal, because we can appreciate the single valve and cross-section as well. So it's a really nice view to confirm, particularly in cases that aren't as straightforward. I also will look at the papillary muscles, particularly, for instance, if you have suspected Schoen complex or any abnormalities in the left side, just to confirm that there are two papillary muscles. As you're just sweeping down, if you have really nice imaging, they're pretty easy to appreciate. And you should be sweeping with color as well, again, looking for ventricular septal defects. So from the level of the great vessels all the way down to the apex and moving slowly to make sure that you're not missing any small ventricular septal defects. So now moving into the arches. So just a quick review of what we're seeing here. The ascending aorta, transverse aorta, we can see if we get really nice imaging, we can see all three branches coming off. The area of the isthmus, which is just after the left subclavian, as well as the ductus as it inserts into the descending aorta. Your right pulmonary artery sitting here as well. And your innominate vein sits right on top of these head and neck vessels as well. So when I'm looking at the aortic arch in long view, I am looking to make sure that I don't necessarily need to see all three, although I would like to, but confirming that you are seeing these head and neck vessels to make sure that you're on the arch and not on the ductal arch to confirm that it's normal. With the color flow, again, just looking for nice, smooth flow, that it's all forward flow, that there's no reversal or color flow disturbance in the area of the isthmus, and that this is all nice and smooth and laminar. Your ductal arch is, just takes a little bit of a tweak to the probe to move into this, and it has a little bit of a different configuration to it. In this view as well, we can also appreciate the two branch PAs, so right PA, left PA, ductus. So this is a really nice view to confirm that you have a nice wide open ductus arteriosus. And it should be connecting to the descending aorta. And when I put color on, I make sure and include the pulmonary valve. So I'm wanting to see that this forward flow is going all the way from the level of the valve down to the descending aorta, and that I don't see any flow disturbance. And then moving into the bicaval view. So I think this is a nice sweep because it is very close to the level of your aortic arch as well. And we can actually appreciate a lot of anatomy from this view. So just taking a step back, I've labeled it cranial, up to towards the head, towards the feet. We have our right atrium, our SVC entering here, IVC, eustachian valve, which I will show you in a clip, as well as your left atrium, and your right pulmonary artery in cross-section. So eustachian valve, and I bring it up because sometimes we also will see this in the four-chamber view. And we've had referrals for fetal echo because they're not too sure what this membrane is, so I think it is important to recognize its anatomical location and appreciate that it is a normal structure that we do commonly see. So right at the entrance of the right atrium and the anterior aspect of the IVC, you may more easily appreciate it routinely in the bicaval view. We also, I think it was pointed out, can see that the right atrial appendage in this view to confirm atrial morphology, so you can see that as well. And then just to show you what it looks like in the four-chamber view, if you just move just slightly inferiorly, it's actually much easier to see if you're paying attention. But if you see this membrane here, you can follow it down into the IVC. So it's important to know this too, because this can be mistaken for the foramen ovale flap in some cases. People have said, wondered about the flow direction, is it incorrect? So again, just knowing the normal anatomy is going to help you in your screening process. And we're also looking for symmetry. We want to make sure that the IVC is coming from the liver, draining into the right atrium, SVC as well, and they should be similar in caliber. So once you start seeing any differences in proportions, you have to start thinking, where's the extra flow coming from? Why is one vessel bigger than the other? Is there TAPVR, either coming from the supracardiac or infracardiac? Is there an absent ductus venosus? Is there a vein of Galen's? There can be different reasons for increased flow coming back to either of these vessels, but it definitely needs to prompt you to do some investigation. And you will notice as well that this drainage point just at the point before the IVC comes into the right atrium will be a little bit larger, just because you have the hepatic veins as well as the ductus venosus all merging at this level. So a little bit of slight prominence at this level is okay. Color Doppler, as part of the guidelines, is used to confirm presence of flow. And again, if there's any question about proportions, color Doppler can be helpful to help you decide. And I do use the directional power Doppler with this as well, just because we are coming in at a poor Doppler angle and there's not much we can do about it. So this will help fill in better than the color Doppler. The other thing I use this view for, since we can see both the right and the left atrium as well as the foramen ovale flap, this is another view that we can use to confirm that the PFO flow is correct or abnormal. So you can, it's another alternative view to think about if you're having trouble in the four-chamber view. And then finally, M mode, which we've heard. So we want to see that the heart is squeezing, not rocking. It should be a normal danceable rhythm with one-to-one conduction. And then we just take M mode measurements, making sure to include both the ventricular free wall as well as the atrial free wall. So again, the biggest advice I can give when you're doing a fetal echo is just to be methodical, to always practice in the same predictable pattern. For me, it's 2D first, I make a decision, color helps me confirm, pulse wave Doppler if I need it, and then knowing what's normal is going to be the number one thing you can do to recognize heart disease as well as obtaining pristine images. So, thank you.